Welcome to the latest episode of the Public Health Insight Podcast. My name is Gordon, your host for this episode, along with my co host LaShawn. And in this episode, we confront a heartbreaking reality in Taliban controlled Afghanistan, where despair is gripping women, leading to a concerning surge in suicides.
Then, we'll shift our focus to the rising threat of superbugs, those resilient bacteria that are overpowering our antibiotics. We'll explore an innovative approach called phage therapy as a potential lifesaver.
Finally, we journey to Canada, where policymakers are urged to let evidence, not opinion, shape harm reduction policies amidst a drug poisoning crisis. Stay with us as we navigate these pressing public health challenges and have discussions about solutions that can make a difference. Let's go.
Since the Taliban's resurgence in Afghanistan in 2021, there has been a disturbing surge in female suicides and suicide attempts, according to the data from healthcare providers. The Taliban has not publicly disclosed suicide statistics and has restricted health workers from sharing up to date figures, but the data paints a grim picture. In a stark departure from global trends, more women than men are dying by suicide in Afghanistan. The restrictions imposed on Afghan women, from a ban on education above elementary level to prohibitions on work and public activities, have been linked to this mental health crisis. Experts fear that the situation will worsen as the Taliban tightens its grip on women's lives, leaving many with despair as their only form of protest in a country where their public presence is being erased. So, Gordon, obviously devastating. What's your reaction to this?
My immediate reaction when I came across this article is that more women than men are completing suicides. The significance of that is that's very uncommon for any jurisdiction or country, in that you find that women have more suicide attempts and self harm injuries that result in hospitalizations, but not where a death is completed by suicide. That tends to be men around the age of 35 to 54 is where we see a lot of men dying by suicide. So in a society where that's completely flipped on its head, it's very puzzling and it raises a lot of cause of concern, and that's what gripped me to explore this article even further.
Yeah, absolutely. And like the contextual factors here, like the war, conflict, poverty, the mental health burden, a lot of the freedoms are being taken from these Afghan women. And with that, there's the loss of freedom and hope, domestic abuse, forced marriages, and the different avenues that have traditionally been used to report such things have been
Mhm.
taken away. So you can't even report this at all anymore. And it's leading to a lot of what we're seeing with these disturbing statistics of increased suicide amongst women in many areas of Afghanistan.
Yeah, the trouble with it too is we know and we can assume that it's an underreported number too, because
Hmm.
there's factors religiously and culturally where
Hmm.
families don't want to necessarily say that their family member passed away by suicide because of the stigma and shame, and
Hmm.
perhaps worries about getting in trouble, for example.
Hmm.
So we know that it's perhaps even worse than we're being led to believe right now. And that's, again, another cause for concern, especially when we look at the oppression of women and the loss of rights of women in those societies, and the mental health crisis and toll that that places on women not getting access to the basics of life and the social determinants of health. And again, we'll talk about this in a future episode where we have to ask the question why. So these rates are increasing specifically in this society. LaShawn has already outlined some of the factors that go into that. And reading this article, it was very disturbing to see the different accounts of the people who pass away by suicide telling their friends and their family members exactly what they plan to do if the situation doesn't change,
Hmm.
indicating that there's just simply no hope for a lot of different families down there. So that's very sad, quite frankly, to read about and not being able to do anything about sitting in my chair doing this podcast. It's quite sad. Before we move on, I think it's pertinent to say too that September is Suicide Awareness Month as well. And September 10th, I believe, is World Suicide Prevention Day. So if you or someone you know is in crisis or thinking about suicide, just know that supports are available. And just by typing the word suicide into Google, it shows you the nearest supports that are available to you in person and virtually too. So I'd encourage you to use them if you're in that situation or recommend them to others that you know who may be in that situation. The rise of drug resistant superbugs, driven by antimicrobial resistance, possesses a silent but imminent pandemic threat. Despite being initially overshadowed by antibiotics, phage therapy, which is using bacteria destroying viruses known as bacteriophages, is gaining attention as a potent alternative. Phages, nature's microbial predators, offer a tailored approach to combat infections. Health Canada has approved their use in food safety, but not yet in healthcare settings. While countries like Georgia and Belgium have embraced phage therapy, Canada has lagged behind, with only limited trials. Awareness and regulatory hurdles remain, but promising phage centric startups and research initiatives are emerging. As the AMR crisis looms, phage therapy could be a crucial weapon in our arsenal against superbugs. LaShawn, what's your reaction to this? Are viruses the solution to antimicrobial resistant superbugs? Help me
Not
work that out.
viruses. They're not viruses.
They're viruses.
No.
Yeah,
Bacteriophages?
yeah,
Really?
yeah,
I'm
they're
gonna fact
viruses
check that. Hold
by
on.
classification.
Are bacteria
They're viruses that target bacteria. That's the only difference between like a COVID, for example, that
Oh
target human
frick, you're
cells.
right. Okay.
Yeah.
Well, you're right.
Listen,
My
uh,
reaction is I'm surprised it's a virus.
bachelor's of microbiology and immunology right now.
Hey, I did my bachelor's in biochemistry and biology and I learned about this,
You went
but
DT.
yeah, they always taught it as a
Anyways,
separate thing. But anyways,
mm,
yeah, I mean, this is interesting. This is actually very, very interesting. I mean, there's been a plume of just talking about bacterial and microbial resistance for some time now. And I think we've kind of reached that point of where we're just like, we're screwed. What can we do about this? Let's talk about innovative
damn.
strategies and solutions. However, we don't need to be innovative when it comes to this at face value because there's this
Mm,
thing back in the 1930s at its heyday called phage therapy that has been used to combat a lot of these infections as opposed to using things like penicillin and antibiotics. However, due to the commercialization and the growth of antibiotics in that time period, the phage therapy kind of took a back seat and got forgotten about. However, like I mentioned, this plume of just realizing, hey, we're screwed. A lot of these antibiotics are not working. There's a lot of antibiotic resistant bacteria out there for simple procedures that we're having in hospitals that used to be relatively simple to do. There's a huge risk of having resistant bacteria cause infections, which leads to loss in lives. And we're really facing a crisis at which we can get to the point where this antimicrobial infections they will overtake cancers as the leading cause of death by 2050, which is absolutely mind blowing to me. So, the fact that we're starting this discussion and talking about an old friend, if you like to say, phage
mm.
therapy, gives us a glimmer of hope in a rather bleak landscape.
Yeah. There is a reason, though,
Hmm.
that this has not been implemented more widely to date. You did bring up some good points about sort of that arms race between the bacteria evolving to become resistant to the rate in which we can discover new antibiotics. We haven't discovered a new antibiotic for, I would say, more than a decade or two at this point. So we are now forced to explore new avenues or revisit something that we have knowledge that has worked in the past, phage therapy. But there are limitations such as will a hospital cover it? What's the cost of the phage therapy?
Mhm.
There was an example in this article that we're referencing specifically where phage therapy had to be shipped across the border, and
Hmm.
it gave the example at the cost of that from Texas to Toronto. The cost of that getting that phage therapy would be the equivalent of taking a cab from Texas to Toronto. And I don't want to work out the math in that because I think the
Huge.
number would scare me.
Yeah.
So we still have a long way to go before this can be scaled up. But given that it does seem like we're out of options, we should explore this as a safer alternative as far as we know to mitigate the danger of antimicrobial or drug resistant bacteria overtaking cancer and other types of things as the leading cause of death. That's something that's very important. And it allows for that personalized medicine too, because a lot of times you have an infection before it's cultured or before anyone knows what's causing it. You do broad spectrum antibiotics where the doctors will prescribe several different antibiotics because they're not really sure which one it is. That then contributes to antimicrobial resistance. But then if you use phage therapy where it's customized to a person's specific infection, you can mitigate a lot of that. So it does show some promise, but we're a little bit ways away from scaling this up worldwide.
Yeah, and it's interesting. I don't know if we should consider this an alternative more
Mm,
so than a part of our toolkit to combat these
complementary.
type of
Mm,
infections. And it reminds me to my throwback days working in the neglected tropical disease space. We used to talk about the fourth leg at the table being neglected tropical
mm,
diseases, in addition to HIV, tuberculosis, and malaria. In this case, we're going to use that same table example, but we're going to talk about our arsenal, our toolkit to combat some of these diseases. We're talking about, first of all, we're talking about phage therapy as one of the legs, vaccines as another one of those legs, antibiotics as that third leg, and finally, your natural immune
the good
system.
old, the good
Good
old
old
immune
natural
system.
immune system.
T
And
cells, B cells,
exactly,
macrophages,
using that as
neutrophils.
kind of a toolkit to attack these things rather than relying
Mm.
on one. The unregulated drug supply in Canada, encompassing opioids and other substances, poses a severe public health crisis. Despite over 2 decades of evidence supporting harm reduction strategies like supervised consumption sites, policymakers continue to resist their implementation. Recent attempts to defund safer supply and deny access to heroin assisted treatment reflect ideological biases over empirical evidence. The crisis has claimed nearly 40,000 lives since 2016 in Canada. Yet, urgency in addressing it lags sorely behind, especially in light of the progress we've seen in the COVID 19 pandemic. Now, to move this forward, prioritizing evidence over stigma and ideology, embracing collaboration, and putting the need of vulnerable individuals first is essential. So, Gordon, help me connect the dots here a bit. Unregulated drug supply in Canada. It's causing a lot of poisonings and a lot of people are dying. Why isn't there a lot of attention?
Unfortunately, there is a lot of attention on it, just not the right attention.
Hmm.
And I think this goes back to the quote I probably bring up in every podcast, and it's about identifying the problem, right?
A problem
You
have
remember
to
what that
blah, blah,
quote
blah,
is?
blah, blah, blah. John Dewey. My name is Gordon.
Blah, blah,
Blah,
blah,
blah,
blah,
blah.
blah.
All right, go ahead. Let's hear it
John
again.
Dewey, right?
Let's hear
A
it.
problem well defined is a problem half solved.
Hmm.
So we're talking about the unregulated drug supply. We understand that something like heroin assisted treatment or safer supply is not fixing the root cause of what led someone into trying opioids or street drugs in the first place. A lot of the people experience trauma in their lives, are using it to escape from their situations. A lot of times there's domestic abuse involved, trauma and loss and grief. It's not addressing that, and we get that. But people are dying from taking street drugs. And the reason that they're dying is because it's being laced with things that they're unaware that's in there, right? So a lot of what the harm reduction approaches that we use now acknowledges that people are going to be using substances whether we like it or not, whether you believe in there was that show on A&E I used to watch like 20 years ago. It was called Intervention, and it was centered all around not enabling people.
Mm-hmm.
We have a lot of information now to know that the way we've been addressing addictions is just completely wrong. And this is where harm reduction approaches come in. So what stands out to me is, hey, 40,000 deaths later, we're still
Mm-hmm.
really talking about it like this. That's a little bit sad. And then two, we as public health professionals are told and instructed, go out there and find something that works. Over decades, harm reduction approaches have been refined, studied, measured. We collect the data, present the data, and it doesn't fit with the preconceived notions that policymakers has.
Mm-hmm.
And because of that alone, things are being blocked or not being allowed to move forward. That's when we as public health practitioners are in a little bit of a pickle, because we've told you to take courses on economic evaluation and evaluation. You've done all the right things, yet policymakers still hold the ability to make a decision. And that comes at the expense a lot of times of public health evidence. And that's exactly what we're seeing in this case, where it just doesn't sound right to give people more drugs, right? Heroin assisted treatment. Why are we giving people heroin? Well, this is medical grade. There's no chance of it being contaminated and someone dying from something other than what they intended to take. The goal of this is to save lives for people who are struggling with addiction. There needs to be parallel strategies that needs to be implemented that address the root causes, but the purpose of this is not that.
Mm-hmm. Yeah,
It's not that.
and context is so important, right? Like you mentioned, prominent political figures in Canada might be using that exact statement, right? Like, why are we injecting more drugs into people who are addicted? That
Yeah.
causes a lot of shift in perception about these harm reduction strategies, safe supply types of interventions that have, as Gordon mentioned, had incredible success and positive outcomes in a variety of situations in Europe, in Canada, in many contexts. So, really, that framing and being able to combat misinformation rears its head again in this situation as well.
You know what the sad thing of all this is, LaShawn? It's how much is a life worth?
Mm,
But society doesn't value all lives the same. And
yeah.
I think that's what we're really talking around here, what politicians are talking around, because
Hmm.
if you think about it, this is no different from an acute response to an immediate health issue. COVID, you build hospitals, you told people to stay home, okay? Some people still had parties, went to the hospital, needed to be hospitalized. You're not then denying access to care because you felt people made the wrong decisions.
Hmm. Yeah.
But because people who struggle with addictions are seen less than a full human, we can justify not providing the same level of response and care to them.
And that's the thing.
So I
It's
think that's what it really
yeah.
comes down to be quite frank. In this episode, we discussed three very salient articles, one focusing on female suicides in Afghanistan and the factors that are driving that, the second focusing on superbugs and how a new old way of thinking called bacteriophages can help us alleviate the burden of antimicrobial resistance. And lastly, how best can we engage with policymakers around harm reduction when ideology is way more important than evidence? This was Gordon and LaShawn, your favorite public health professionals, signing off. Until next time.
Peace.
Peace. Thank you for listening to the Public Health Insight Podcast, your go to space for informative conversations, inspiring community action. If you enjoy our podcast, be sure to subscribe and leave us a rating on Apple Podcasts or Spotify. See you in the next one.